Hello and welcome to Pain Options Education. This is the place for discussion on topical issues in musculoskeletal pain, for a common sense take on current research and evidence, and to help fine-tune your clinical practice and clinical reasoning and all other things that need to be refined. I'm Darren.
I'm Tim.
How are you today, Tim?
I'm as fine as the weather, thanks, Darren.
Good. We're continuing our discussion around pain sensitivity in the pain sensitivity series here. And this is part 4, focusing on pain sensitivity in the physical examination. So clearly the physical examination is a broad thing where there's lots of components, but we are focusing down on things that might be specific to pain sensitivity today. One of the things, we still want to define pain sensitivity and check. So how have we defined pain sensitivity, Tim?
Well, you should know you've defined it in the last 3 episodes, Darren.
Okay, well, I'll define it again as pain sensitivity in the clinical context can be considered as a term used to encompass the phenomena that some people's experience and perception of pain is enhanced beyond that of others.
I'm still happy with that.
Good.
But the physical exam also informs this because that gives us more information after speaking to them about their experience and perception of pain. So when we do different tests, that information is very important to putting the picture together.
Yeah. And this is just a reminder that we're taking these concepts of QST, though I think now it should be called QQST, based on previous discussion, and CST, which is the clinical implementation of those similar tests.
Yeah.
But certainly the approach that we're going to describe here is around a system that is minimally invasive in terms of the time and effort that it takes for the therapist to perform.
Yeah, and a comment here around the quantitative sensory testing is that people may say, well, that requires laboratory equipment and you can't be measuring these things exactly in the clinic using these clinical sensory tests, which have been just started to be researched, I guess, to see how well they match with the quantitative. But my short answer to that is I don't care. The reason being is we're using some of these tests to add information about someone's presentation. We're not trying to make black and white conclusions around they've got central sensitisation or peripheral sensitisation. Just knowing that there's increased pain sensitivity or they're broadly more sensitised in their presentation, that alone is really helpful in explaining that to the patient, but giving us a picture of where we might head to help guide this person to get better.
Yeah. So for clinicians, it might be a struggle where this fits in the examination cycle, and people's examination of patients can become quite routine and structured.
Yeah.
So adding in another thing could be problematic. We've kind of talked about it in these terms, and they're not the be-all and end-all rules, but for the clinician wanting some guidance around where does this fit or where do I start with the patient, maybe this would help. I especially found you a red flag here because I know how fond you are of that, and probably mistakenly should have had that in the last presentation by the looks of it. But I'll just roll through these 4 things and then just get your thoughts. So first, if the person comes in and from the subjective assessment, there's the potential for neurological compromise, and by that I mean a disturbance in conduction of the nerve system, then probably you should start with neurological screening for conduction. If a person comes in and the source of symptoms is a priority, then probably you would start with pain provocation testing to see where that patient's pain is originating from as best you can.
So what do you mean by the source of symptoms being a priority?
Well, maybe you've been referred somebody by a pain medicine specialist that says, well, I'm not sure if I should inject this person's lumbar spine or sacroiliac joint.
So someone may say no to either circumstance. But yeah, when you're trying to identify...
Yeah, or someone might come in with the belief that their pelvis is out of position.
Yeah.
But actually from listening to their story, you're thinking, actually, I think this is the lumbar spine, not the pelvis.
Sure.
Yeah.
Or back versus hip, for example.
Exactly.
Shoulder versus neck,
yeah,
for example.
Yeah, so they're the examples of that. If someone comes in and the source of symptoms is not such a priority, everything else being even, starting with functional testing is a good place to go.
Mm-hmm.
And then lastly, if there's subjective indications that pain sensitivity is a very significant issue for this person, or even a moderate one for that matter, then starting with pain sensitivity testing probably is the way to go.
Yeah.
And that's particularly around the influence that could have on your testing of those other tests we've just spoken about.
Yeah. So arriving at that decision comes from what we talked about in the last
Yes.
presentation around putting those subjective components together, so understanding their story, and then by the end of that, before you start your physical examination, it should be pretty clear, hang on, this isn't a typical nociceptive mechanical pain presentation.
Yeah.
Yeah. Can you think of an example of a patient that might be helpful to highlight that, where you've gone straight to the pain sensitivity assessment at the start of your consult?
Oh, well, I could think of 20, 30, easy. There was one just the other day. I can't remember the patient, but I can remember the comments of the treating therapist that came in.
Yeah.
And for me, that was probably, it wasn't clearly a pain sensitivity dominant issue, but there was 4 or 5 things in there around constant pain, some things around sensitivity that just made me feel that might be an issue. So it wasn't like I'm 100% that's it. I'm maybe 70.
Yeah.
And so I started with the pain sensitivity assessment in that case, and the therapist was quite surprised by that and actually thought, oh yeah, I can rethink the way I go around this. Because in the end, those tests for sensitivity were positive than any other. So I could stop there and educate the person, and we'll talk about that, I think, a bit more towards the end of this today's talk. But then also that means when I go to do tests around the source of symptoms, I can interpret that understanding that everything's painful.
Yeah, that's the big one for me, where let's say it's a shoulder problem.
Yeah.
And someone's had some investigations that do perhaps show some bursal changes and some rotator cuff tendon changes, and there's been a focus on that.
Yeah.
But when you listen to their story, their symptoms are much more widespread, less mechanical in their behaviour, and it's quite clear that their focus is around finding the pathology, but that's not fitting with their story. So in that instance, I'll do some sensitivity tests first, because the danger could be I'll do some movement tests, and what do you know, they hurt. I could do some subacromial tests that load the subacromial structures, so your more orthopedic tests, and what do you know, they'll hurt, and I might just pick on 1 or 2 areas to poke on, and they'll hurt as well, and I could be very distracted by going, you've got a subacromial pain problem.
Yep.
Whereas if I poked on a few more areas or did these sensitivity tests early on, then you get a very different clinical picture.
Mm. And I think that make me think that we should actually almost do a one-off session in the differentiation of shoulder from neck, shoulder, arm pain. And I remember when I went into manipulative physiotherapy training in the year 2000, that was one of the 2 problem issues that I didn't know how to deal with. So maybe we could do a special episode just on that, I think.
Why not?
Why not? All right, next. So we're breaking it down to these kind of 4 tests that you can do simply with the person right there and then, no necessary additional equipment needed. And we think from these you can get a relatively good sense of the person's overall sensitivity in terms of their presentation. So that's light touch sensitivity, sharp sensitivity, deep pressure sensitivity, and cold sensitivity. We will show examples of those in a minute, so we don't need to speak about them specifically. What I do want to talk about is just broadly what kind of response type you're looking for and response location. So often when we're talking pain sensitivity, it's easy to think about the person with heightened pain responses. So the response type would be that of something being heightened. Actually, we didn't speak in the subjective around the term disproportionate, and I think that's an interesting term that was off-putting to me initially, but actually I don't think there's a better term, and because that's what it is. You get a response from somebody that's disproportionate. The classic being allodynia, where something that shouldn't be painful is painful.
Yeah, so that's the sensory gain concept,
Yes.
where there's an elevated response.
Yeah. I think it would be remiss of us not to say that there is complexity in this. And just because someone is elevated to light touch and has allodynia doesn't mean they will have elevated response to other forms of stimuli. And in fact, they may have allodynia to light touch, but reduced sensation to sharp sensitivity, for instance. There is literature that documents this. Think of the studies by Bree and Neve that have looked at this kind of neck, shoulder, arm pain.
Yeah.
And certainly they both describe separately samples of people where one of these tests might be elevated or gain, or the other one might be lost. So that can be a confusing concept. But I think because in a basic logical thing, you'd think if one's elevated, they're all going to be elevated, or at least some of them will be elevated. Not that some will be elevated and some aren't. In the end, my interpretation of that is that, well, if you have both of those, fine. It just means your body isn't processing that information normally.
Yeah.
Okay, good. So response types, anything else you want to say around that?
No, I think that's pretty clean.
Yeah. And response locations.
So obviously you get a response one way or the other around where you're applying the stimulus, which is important, and that's very helpful when you've got, for example, on a limb, you can compare it to another limb, so it's easy to see a difference around that. But then the response location might be more varied or widespread than that. So obviously your typical, we think of distal referral of symptoms. If you're doing something on a low back, a sharp testing, for example, you might get spread of symptoms to a limb. But as you'd mentioned in an earlier talk, you can get strange things in different body regions that seem completely disconnected or unrelated. So it's really about approaching it with an open mind. Nothing's right or wrong. Applying a stimulus, asking the person what they're experiencing.
Yes, and again, you're really just testing this person's ability to process information, and we'll talk more about this in the caveats when we get to that in the final episode. But yeah, we're just making a judgment on how they process information and stimuli, not on specific, anything more specific than that, really.
Yeah.
Great. So we'll now cut to some videos of you performing these tests, and then we'll come back and discuss that after.
Okay, so we're about to have a look at some assessment of your back, Jenny. But just to clarify, you've had this for nearly 12 months now, where it's really been pain in your low back, but it's just been broadly radiating down your left leg.
Yeah.
But the pain's more localised to the left side of your back. And you didn't have any specific injury or anything when this started.
No.
And you've had some scans on your back that are actually clear, so they don't show any signs of disc problems or pinched nerves or anything.
That's right, yeah.
That's your understanding? Good. So we're just going to do some tests first, because you've described that this area is quite sensitive and it can be easily stirred up, and similar with your leg pain. So we're going to do some tests around sensitivity, and these ones are just of your skin. So we're interested to know, even at a skin level, is your back or your leg sensitive, or is the issue deeper in than that? Okay, so we'll do these tests first. If you just stand and face with your back to me, good. So I'll use this tissue, so it should feel like, if I brush on your arm, it should feel like a tissue. Can you feel that?
Yeah.
So now I really want a comparison in what you can feel on the left and right sides of your back. So if I do the right side first, can you feel that?
Yeah, I can.
And what does that feel like?
It just feels like a tissue.
Okay, so similar to your arm?
Yeah.
And if I do it on this side, can you feel that?
I can, yeah.
Okay. Is that different to the right?
Yeah, it's more on that side.
So is it painful, or you just feel it more?
Just feel it more.
And if I compare this again to this, Do you feel it a little bit or a lot more?
Yeah, quite a bit more on the left.
So it's clearly more sensitive,
Yeah,
but not painful.
that's right. Yeah.
Okay, good. Okay, so similar to what we did on your low back, we're just going to repeat some of that on your leg now.
Okay.
So we'll use the tissue again,
Yep.
which feels like a tissue. So when I brush on this thigh, compared to this thigh, does that feel any different?
Feels the same.
Okay. And then if I brush on your lower leg there, can you feel that?
Yep.
And can you feel that?
Yep.
And do they feel any different?
No, they feel the same.
Okay. So I'll just come down onto your foot now. So if we do that on your foot, compared to this side, any different?
They feel the same too.
Okay. So interesting, it was different on your back, but there's no obvious difference there. And that's in the areas where you do feel those symptoms
Yeah.
sometimes.
Yeah.
Okay, good. Okay, the next test we're going to use a toothpick. So this just tests if you're sensitive to sharp.
Okay.
So it just tests slightly different nerve endings in your skin. So if I show you on your arm, that should feel like a toothpick.
Yep.
Can you feel that?
Yeah, it feels sharp.
So that feels sharp. So remember what that's like,
Okay.
just facing that way again. So we'll start on the right side of your back. As I tap down here, can you feel that?
Yeah, I can. Yeah.
And what do you feel?
Feels like my arm feels sharp.
So it feels sharp.
Yeah.
So again, I'll do that, and now compare that to the left side.
Yeah.
Is there any difference in that sharpness?
It's actually really sore.
So that's
Yeah.
actually sore.
Yeah.
Okay. So if I start coming down, tell me when it starts to get painful.
You're about there.
So it's painful now.
Yeah.
Okay. And is that similar to your pain that you feel in your back, or the similar area?
It is, but I can also now start to feel that in my leg as well.
Okay.
You know, the top half of my leg.
That's important. So when I tap on your back, you feel that radiating down your leg.
Yeah, and in my back as well.
Okay. What do you make of that, given that's just on your skin there?
Well, I guess it shows my back and my leg pain are linked somehow, and
Yep.
it's more painful on the left.
Good. Okay, Jenny, so similar again to what we do on your back with the toothpick. If I come down on this thigh, can you feel that?
Yeah,
And what does that feel like?
just feels sharp.
Okay, if I do the same thing on the other side, can you feel that?
Yeah, okay.
And what does that feel like?
That feels more sharp on that leg.
So more sharp. So it's clearly different from this leg?
Yeah.
By a little bit or a lot?
Fair bit, yeah.
Okay, so clearly different.
Yeah.
Okay, good. So we'll say it's sharper on this side than that side. If we come down the inside of your leg now, can you feel that?
Yep.
And how would you describe that?
Same as here.
And if we come down this side, can you feel that?
It's definitely sharper on that side.
So that's sharper again. Similar response to the thigh.
Yeah, similar to that.
Okay. So I'll just do the outside of your thigh, of your shin. How is that?
That's sharp. So all the same inside and outside
So
leg, but
Both
sharp.
of those are sharp. Does it feel sharp down here?
Yes.
And is that sharpness different to this?
Yeah, it's more on the left foot.
Okay. So what we've got there is pretty much the whole leg. It feels clearly sharper than the right side.
Yeah.
And what do you think that means?
I don't know.
It's interesting though, because it's clearly different, isn't it?
Yeah.
Okay, good. That's helpful. Okay, you're doing well. We're just going to test with this ice now. So again, it's different nerve endings in your skin to see if you're sensitive to cold. So I'll put this on your skin for 5 seconds. And I want to know from this, is it actually cold or is it actually painful when I'm doing it? So I want you to give me a score out of 10. 0 is not cold at all. 10 is burning or freezing cold. So just after 5 seconds, can you feel that?
Yeah, it's definitely cold.
So it's cold, and give me a score out of 10.
In the middle, so 5 out of 10.
So 5 out of 10.
Yeah.
Good, facing that way. We'll do the same thing on your back now. So we'll start on the right side here. So as I place that on for 5 seconds, can you feel that?
Yeah, I can.
And how would you describe that?
Pretty similar to my arm, so 5 out of 10.
So that's
cold.
a 5? Yeah. Okay, it's the same thing on your left side of your back. Just wait for 5 seconds. And can you feel that?
I can, yeah.
And how's that compared to the right side?
It's not as cold as the right. It's more down around a 3 out of 10.
So that's only a 3 out of 10. So
Yeah.
less cold on the left compared to the right.
Yeah, less cold.
Okay, good, thank you. So we'll come onto your thigh now, same thing, so just wait for 5 seconds. And how cold would you rate that?
Same as the wrist, so 5 out of 10.
So about a 5. If I come over to this side of your thigh, how would you rate that?
That side's not as cold.
So it's less cold.
It's less cold on that side.
So what score would you give that?
So give that a 3.
So it's a little bit colder.
A little bit colder.
Okay. Is there any pain with that or no?
No, it's less.
Okay. So on the outside of your shin?
Yeah, that's less. Well, it's same as similar to that one, a 3.
A 3.
Yeah.
Versus if we do it on this side?
So it's more on that side. That's a 5.
Good.
Yeah.
And if we come down to your foot on the inside here, what would you score that?
It's still a 5. Yeah.
Okay. And if we do it on the inside of this foot?
It's just that little bit less again, a 3.
Okay. So broadly, that whole leg is a bit less
Yeah.
in terms of how cold it feels.
Yeah.
So that's a bit interesting compared to the other test, isn't it?
Yeah, I wasn't expecting that.
No, we'll come to that. We'll just do one more test and then we'll come to the reasons behind that.
Okay.
Now that we've used the ice on your back, has that stayed sensitive or has it calmed down again now?
No, it's just normal.
Okay, good. And sometimes people, the pain will actually increase as we keep doing more of these tests. Have you noticed that with you at all?
No, not at all.
Okay. Now I'm just going to press on your back now because some people are just sensitive to pressure. That's not from pushing on a damaged part. They can just be sensitive to pressure. So if I did that on your forearm, if we do light, then moderate, then firm pressure, is that painful or do you just feel that pressure?
It just feels like moderate and firm.
Yeah. So we'll do that on your back. Again, we'll start on the right and we'll see if it's painful or if it's any different side to side. Okay. So just coming on the right side of your back here. So just with light, moderate and firm pressure. And you feel those okay?
Yeah.
And was there any pain with that?
No, not at all.
And then I'll do the same on this left side. So just light, moderate and firm pressure. Is that any different to the right side?
Yeah, it feels like you're pressing harder on the left.
Okay. So I'll do that equally on both sides, but in a different spot, so a bit lower down. So if we do light, moderate and firm pressure, would you say there's a difference left to right?
Yeah, I can feel it more on the left.
Okay. And if I come up a bit higher, same thing again, light, moderate and firm pressure.
That feels more similar there.
So that's more similar. So you're a bit more sensitive on that left side to the pressure. So if I do it on this thigh, so light pressure, you okay with that?
Yeah.
Moderate.
Yeah.
And then firm. And you can feel those okay?
Yeah, definitely feels firm.
Yes.
Yeah.
Is that much different to your wrist though?
No,
Okay.
the same.
So if I come onto this side and do light and then moderate, are you okay with that?
Yeah, it feels like you're pressing harder on that side.
Okay. I'll do a comparison then, so that feels a bit different, doesn't it?
Yeah.
So if I just use these fingers and I'll do light and then moderate and then firm, is there a difference there left to right, would you say?
Yeah, it definitely feels like you're pressing harder.
So it feels like I'm pressing harder.
Yeah.
I'll do the same manner down here. If we do light and then moderate and then firm, any difference side to side with that?
That's the same.
So that feels equal.
Equal, yeah.
And then same on the outside. So light, moderate and firm.
Yeah.
Any difference?
No, it just feels like firm pressure on both.
So you're a bit more sensitive in your thigh to firmer pressure.
Yeah.
Okay, good.
Okay, we're back, and thanks for that fantastic demonstration, Tim, that I'll see one day. But is there any other final comments before we get on to paper of the day around those tests that you want to bring up?
Yeah, from what you just saw, what we demonstrated then, it varies for each people, both the response, but we've given an example of the language that you might use in an instance. There's very different ways of approaching this, and you may question it, how technically correct is that? But we'll come later to what we're interpreting out of those tests, which is important, and our knowledge of this will shift and change as we do learn more in this area.
Yeah, two things from me. One, yeah, you could do just one of these tests, but I think if you do 4 of them, you get a better picture of the person. So 1's okay, 2's better, 3's better again, 4's better as far as I'm concerned. Yeah. Though in some cases, if someone's highly allodynic, then you're not going to move on to the other test because you don't want to wind them up. Yeah. So there's got to be some common sense around that. Yeah. Number 2 is really just the warning around extreme responses to this testing. And I have had a person that's had an acute anxiety attack during this kind of assessment, and I know I'm not the only one that has. Yeah. So you need to be prepared for that in some ways, and if it happens, treat the person with respect, help them wind down.
Don't panic.
Don't panic yourself. That's the worst thing you could do. Reassure them, and then when they do wind out a bit, it's a perfect time for some kind of reflection on their part, reflective questioning.
Yeah, and I think also around that, the warnings of you may have symptoms later on, because we know with this sensitivity you can have latent pain which comes later on. But hopefully you've got from the person's story at the start what their symptom behaviour is like.
Yes.
So then you can judge how much of this testing you might do, for example, or you might leave it to your second or third consult once there's a bit more of a rapport with the patient, because that can be a risk of flaring people up.
Yeah. Great. So paper of the day today is one we've already mentioned previously, the paper by Zhu and our friend Helen Slater, and also Bree Tamping, who we know, and looking at the construct validity of low-cost and time-efficient clinical sensory testing battery to evaluate somatosensory dysfunction. I did have a quote for you, but you've already answered it, Tim, and the quote is, "The agreement and correlation of CST parameters with QST varies substantially, not only between different parameters, but also among different patient cohorts." And I was going to ask you, does that matter? And I think you beautifully stated that it doesn't.
Well, it does if you're a technical person around exactly what that means. Did you say that out loud? But in this instance, no, because we're being very careful in what we interpret from these tests. And as I think we mentioned earlier, and we'll talk a bit more with management, this is really useful for us to go, the system's behaving differently, and what that means varies for different people, both in what's causing it and what management's required. So these are just simple clinical tests to give us another piece of information in that person's puzzle that you're trying to solve with them.
Yeah. And look, it is important to investigate tests and test batteries to understand what you're doing as much as you can. But in the end, neither you or I would make a diagnosis based on one test. And
No. And these aren't for diagnosis anyway.
No.
They're for the broader picture.
Yes.
Yep.
Great. So, questions, Tim?
Well, there might be feedback because I think you pronounced that last paper wrong, but who am I to judge? So people may want to email us about that, or they may have other questions.
Yes, well, I do apologise because I can't speak English, let alone can I pronounce that Welsh word.
I could, but I don't want to show off and make you feel bad.
Thank you. I feel much better about that. Otherwise, I might have one of those anxiety attacks we were just talking about. So we'll take stuff from viewers at education@painoptions.com.au and look forward to speaking to you next time.
Very good. Thanks, Darren.